to spend a little time now reviewing for our midterms, right? Midterm, how long do you have for the midterm? What's that? 10 minutes. We're going to have 10 minutes. Everyone knows where the rubrics are, correct?
Course materials.
Has anyone looked at the rubrics? Okay. So, the rubrics are on Blackboard under course materials, right? Just pull them up here. Make sure that you're using the rubrics and not the lab handouts, okay? The rubrics have points assigned to them, so you know it's the rubric, all right? So you can see here, patient seated, 1 point, gown opens posteriorly, 1 point, this is long. Blood pressure cuffs applied correctly over brachial artery, 2.5 centimeters superior to pupil fossa, snug room for 2 fingers, a point. Palpate systolic pressure, a point. You're reporting it within the limits I'm giving you as a point, right? Then you come down here, observe rate, rhythm, and depth of respiration. You give one example of a change in rate, one example of a change in rhythm, and one example of a change in depth, 2 points. Give a possible cause for each of these 3 changes, 2 points. Does that make sense? Inspect the shape and symmetry of the chest and posterior chest. Give 2 examples of thoracic variations you may see, 2 points. Give a cause for each, 2 points. So as you go through, this is what you have to do. This is what you have to say. If you have to say something, it tells you to give me examples. And I'm just going to check off, either you do it or you don't, and there's 100 points worth of things. Does that make sense?
Do we have that in front of us, or do we have to?
No. Talk out of your head. Okay? So practice it. When you practice it timed, okay? Because inevitably when you get in, people get a little nervous and they slow down, okay? The other thing is, I would highly recommend that you not just think of, like, learn it just like a script, one thing for each, you know, or the minimum that I'm asking for. Learn what you're doing, why you're doing it, and just be able to give examples. If you learn just a single thing, you get in and get nervous. I see people do this all the time. They get nervous, they forget that thing, and it just craters for them, okay? The other thing is, if you forget one thing, how much are these worth a piece? 1, 2, 3 points maybe? Okay, you forget something and make it 98. Is that the end of the world?
Yes.
No, so don't freak out about it. Just go through the rest, and a lot of times people remember it, okay? Yeah, I'm shocked actually sometimes when people remember. I think, oh, they forgot this and this, and all of a sudden they're like, I forgot to text our friend this, and they're doing it, right? So go through this. When you practice this whole thing, practice at time. You're gonna have heart or lung. It's gonna be one of those 2, okay? Those are the 2 we're gonna do for this midterm. Both of them, you'll take blood pressure in, and then you'll move into the exam. Does that make sense? 10 minutes total, no stopping between them. So practice, I would say your blood pressure, you need to be able to do it within 1.5 minutes. That'll give you plenty of time to complete the rest of the exam. Does that make sense? Okay. Heart is exactly the same way, just with the heart exam. So
make sure you have the midterm rubrics.
Yeah.
Compared to the final rubrics.
Yeah, and I've had the finals. There's, you know, but today I put them to where you can't see them. So if you go down to rubrics, it's just going to be midterm. Okay, but if you've pulled already, make sure you have the midterm. Go back and pull the midterm to be sure. All right, so here, same thing. Patient positioning. Patient supine, head of the table elevated 30 degrees, a point. Gown opens anterior, a point. Doctor stands on the right side, a point. Here's your blood pressure, the points allotted to it. Palpate the brachial pulse, name the pulse, proper location. Radial pulse, name the pulse, proper location. State that you're inspecting for color, temperature, and edema. State that you're checking for digital clubbing. Describe digital clubbing so you tell me what it is. Does that make sense? So you're just going to go through and do this. So this allows me to see you know the full exam and you have an idea of some of the things you're looking for. Okay? Now the final will be different. The final, you'll still do this, right? This will be part of it. You'll be graded on it. Then we'll add in, you get findings and give me a diagnosis, okay? So we'll build, but this is the first part, okay? So let's do this. Let me kind of go through one real quickly so you can kind of see what it might look like, okay? I'm gonna just remind me of my patient. You just set that. So the way this will work is you'll come in and you'll come over, you'll draw, there'll be some cards upside down. It's either going to say heart or lung, okay? You'll read it, say heart and lung. I'll say prep your patient, which means if your patient needs to take, if I'm, say we're doing heart, I'd say take your shoes and socks off. I'd make sure the gown opened anteriorly. If we're doing lungs, I'd say make sure it opens posteriorly. If you need to go down to the restroom to change it, just run down to the restroom, change whatever the doctor tells you, come on back. Does that make sense? All right, when you do the exam, you'll have 10 minutes. We'll do a countdown timer for you. And depending on where you take it, if it's in here, it'll be up there. If not, we may have a smaller timer. So we're gonna divide you up into half, okay? Take the exam. So first thing we would do is take the blood pressure, right? And let's just say we've already done blood pressure, okay? So after I take the patient's blood pressure, we're here, right? And I have him set up just like we're doing pulse. I'm gonna say I'm checking for the rate, rhythm, and amplitude of respirations. An example of a change in rate is tachypnea, it could be caused by pleuritic chest pain. Example of a change in rhythm, Shane Stokes, caused by a stroke. An example of a change in depth could be hyperpnea caused by increased metabolic demand. And I've done everything I need to do there. Sit up. Go ahead and move to the end of this table, if you would. All right, so if he would have his gown on, I'd tell the patient I'm gonna open the gown. I'd open here, and I'd say I'm inspecting the bony thorax for any variations in symmetry. I'd come around front. I want you to press down, all right, so you can view the chest, pull up and shield. So they would do that with their gown so you can view, right? And then give me some examples. So some things you may see. You can see flail chest caused by fractured ribs, right? You can see pectus excavatum, ingrowth costal cartilages, carinatum outgrowth. So any of these things we talked about, hyperkyphosis, compression fractures, scoliosis, congenital, lateral curvature, right? So then I'm gonna come back, I'm gonna inspect again. This time I'm looking for what? Rashes, masses, lesions, and scars. Same thing in front. Good. Here. All right. Give me an example of a rash. You can see shingles, herpes zoster, right? I could say poison ivy, contact dermatitis, sunburn, UV exposure, right? And then a mass I might see, lipoma, benign fatty tumor, Burchell's nose, sentinel GI cancer, a cyst, encapsulated fluid, subcutaneous. Does that make sense? All right. Then the last thing I need to inspect, I'll come around front. I'm looking for recruitment of accessory muscles of inspiration. I want to know the most common ones, SCM and sternocleidomastoid and scalenes, and then a common cause of recruitment, emphysema. And I'm done with inspection. Does that make sense? So I inspect. Next thing we're going to do is palpate. So we're going to do general palpation. I'm going to tell the patient you're going to feel pressure on your back. When it says explain it to the patient, you don't have to give them detailed. You're going to feel pressure, okay? Let me know if you have any pain or hypersensitivity. Have you had any? All right, let me know if you feel any as we do this. So here, we talked about how we're going to standardize that, right? Come around front, patient needs a shield. Shield displaced. Displaced. Does that make sense? All right, so we do our general. Now, we're going to do chest expansion. You're going to feel pressure on your back again. Right, you're here. Of course, the gown, you're on the skin, right? We're just for purposes here. Take a deep breath. Let it all out. No, let it out. Good. Again. There you go. See the expansion? So, we'll do that. I want to know, I'm going to grade you on your positioning if you do the chest right, if everything's positioned right, the test is correct. And then I want to know what's normal and abnormal. Normal, both sides initiate together, there's no lag. Abnormal, one side doesn't initiate or there's lag. The side of lag or lack of initiation is always the side of unilateral lung pathology. An example of something that could cause that, pneumothorax, pleural effusion, whatever you want to give, that would be unilateral atelectasis. That make sense?
Do we have to give a number, like what the normal range is?
On this one you don't. I do want it on diaphragmatic excursion.
Okay.
So it just kind of, you'll go down and it'll tell you when I want examples and when I don't. Does that make sense? So we've come to palpation. We did general, we did chest expansion, now tactile fremius. Every time you feel pressure from my hands on the new part of your back, I want you to say 99 in a deep voice.
99, 99, 99.
Good. Shield and displace.
99, 99, 99.
Again.
Again. 99.
All right, there you go. All right, does that make sense? And finally, tracheal deviation. Look over your right shoulder, left shoulder, look straight ahead. I want to see you perform it correctly, and then you're going to tell me what might cause a contralateral deviation. Large tumor, pneumothorax, pleural effusion, ipsilateral, atelectasis, fibrosis of the lungs. Make sense? So now we've done inspection, we've done palpation, we're going to percuss. There's two parts to percussion. There's general, and there's going to be diaphragmatic excursion. Let's start with general. Go ahead and face away from me. You're going to feel some tapping on your back, just so he knows what's coming. The normal sound is what? Resonance. Abnormal sounds we may hear, dullness from fluid, right? Maybe hyperresonance from pneumothorax, emphysema. So then we need to do all 14 spots in the back, 12 in the front. All right, easy. Turn around. Does that make sense? I'll listen to the sound to make sure it's nice and resonant. Shield and displace. Start above the clavicle. And you notice up. And you notice I go side, 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 side. I'm not coming straight down. So that's done. We'll turn around the other way. We'll do diaphragmatic excursion. You only have to do this on one side for the practical. Okay, you raise your shirt for me. All right, let your patient know you're going to feel some tapping on your back. I'm going to use a wax pencil to mark some lines, okay? So we're going to start up above T10, right? Hear that change? So went dull. Breath in, take a big breath in, let it hold. The new level of dullness, let it all out. Breath in, let it all out, hold. So now we've got the diaphragmatic excursion. It should be 3 to 5.5 centimeters, right? Something that could decrease it. You could have pleural effusion that's built up, which makes it sound like it's decreased. You could have hemiparesis of the diaphragm. Just give me an example. Does that make sense? Okay, relax. So now we've done inspection, palpation, percussion. What do we have left? Auscultation, right? So we're just going to do general auscultation on this. I'm going to tell my patient, go ahead and clear your throat. Every time you feel the stethoscope touch a new area of your back, I want you to breathe in and out through your mouth, okay? If I go too fast, let me know. Now, on this, we're going to use the diaphragm, and it has to be on the skin. So his gown would be open back here, okay? I can't open it now. Obviously, these would be in my ears, but so you go in and out through the mouth. We're going to pretend this is open, it's on the skin. So we go side, side, right? Five. That's how I do it. No, 9, 6, 6, 7, 7. Does that make sense? Turn around, face me. As we do this, normal sounds would be vesicular over the parenchyma, tubular over the trachea and bronchi, right? Abnormal sounds we may hear crackles from pneumonia. We may hear wheezes from, say, chronic bronchitis or asthma, right? We could hear stridor from upper airway obstruction. We could hear rub from pleurisy. That makes sense? Again, now here, let's pretend you have a gown on, so let's go in. So this is what you'll do anteriorly, right? Does that make sense? So this is on the skin. Start above the clavicle. Good. Pull up. Pull that shirt up for me. You see how I don't stick it under his shirt? I ask him to pull it up, right? Here's up. Does that make sense? And you're done. Okay, so I've told you the things I wanted to say. You know, one thing I didn't say that I should have, and if you forget something, you can come back and say it like this, is during palpation, if the pain gets worse, you're able to make it worse, then that usually indicates a chest wall pathology. Okay, so if you leave something out and you remember it later, then say it.
Do you have to go in that exact order?
You don't have to go in the exact order. I mean, I know the where the stuff is. So if you find a way that helps you remember it, that's fine. You know, just make sure you do everything and do it accurately. Yeah.
Can we move away from auscultation?
What's that?
Or, like if we move away from a certain point, and then all of a sudden remember it like 2 parts later. So that we
Yeah,
go
you can come back and do it.
back and redo
That's fine. Yeah. Yep. Now, one thing I don't want to see is like, you make sure anteriorly, this has to be on skin for that, right? So they're here pulling down. I do not want to see this number. So if the patient had pulled down, ask them to pull it down a little more, you know, have them adjust.
So that's it, like a timer would stop if you were like, I'm done.
Yeah, if you're done and you say you're done, I'm going to say, do you forfeit the remainder of your time? I ask everyone that. Doesn't mean you did well or poorly. You say yeah, and then that's it. But other people will be like, oh, I want to think about it. Okay, they think about it. That's fine too. So it's. Any questions about that? Pretty straightforward. Okay, so if we did heart, it would be pretty much the same way, right? If he's lay down for me. Let's say you did blood pressure, then we start with upper extremity, right? So you'd come here, relax. Radial pulse, right? Brachial. Checking for color, temperature, and edema. Does that make sense? Looking for digital clubbing, you describe it. What is digital clubbing? Bulbous swelling of the nail base and loss of the normal angle where it increases to greater than 180 degrees. So that's how you'll describe it. You'll perform skin turgor. You'll tell me decreased turgor remains elevated, common cause, dehydration. You'll depress 5 seconds, and then you'll tell me normal refill 2. Does that make sense? Let's go back. He would take his shoes and socks off, right? I'm not going to do it now. You'd find posterior tibial pulse, hold it there for a second so I can see you're at the right place, or salus pedis, right? Then what are you doing? You're looking, inspecting for color, temperature, loss of hair, right? Then we'll look for pitting edema. You press at the appropriate spots, and then you'll describe it. It's edema that when you press into it, remove your thumb, depression remains, common cause, heart failure, liver disease, nephrotic syndrome, right? Then capillary refill. You blanch 5 seconds, release, tell me normal refill is how long? 2 seconds, right? So that finishes up the periphery, right? Then we go into inspection. So you'd have your pin light, you'd be here, and I want to see tangential lighting right here at the fossa between the sternal and clavicular head of the SCM, right? And you'll tell me I'm looking for JVP. What vein do we use? Right internal jugular vein. It's located just lateral and deep to the sternal head of the SCM. It's significant because this represents venous pressure. If it's elevated, it should be 3 or less centimeters from sternal angle of Lewis. Elevation beyond that, common cause, right-sided heart failure, right? Then you'd have your patient go ahead, open the gown, shield, tangential lighting here. I want to see you're at the right location, right? And you're going to tell me you're looking for the apical impulse. Where is it normally located? Left fifth intercostal space, midclavicular line. It's significant because it's the left border of the heart. Then you're going to use your light here. The gown would be open, heat shield. I'd look for any other pulsations, common causes of additional pulsations in large chambers of the heart, aneurysms. Does that make sense?
Do you want us to actually count on them, or
What?
for when we're finding the apical impulse?
Count.
Do you?
You don't have to.
Okay.
You do have to count ribs when you auscultate. Okay. All right. So we do our inspection there, right? And now we're at palpation. Relax for a second. I'm going to come down to the cricoid, find the carotid pulse. You'll tell me the normal rate, 60 to 100 beats per minute. Does that make sense? Go ahead and shield back up. Find the point of maximal impulse, pads of the fingers, right? We're going to feel where it's strongest and isolate it, right? Again, significant left lateral border of the heart. If it's deviated laterally beyond that, and it often indicates cardiomegaly.
When you're finding his prod, do you have to actually find his pulse, or you just say the average?
Well, hopefully you can find it.
Well, no, I mean,
I'm
like,
not
you
gonna.
have
I'm
to
not
count
gonna
it.
come behind you and check you on that.
Okay.
You don't have to count it. No, I
Okay.
just want you there for a few seconds so I know you're at the right spot,
Okay.
and then you tell me normal, just like what I'm doing. Okay? So that's a good question. So we did carotid, we did PMI, shield and displace this way. So we have thrills of the heart, lifts and heaves left, right? Look at I'm palpating for thrills of the heart. That's a vibratory sensation I feel under my hand from turbulent blood flow, most common cause of valvular disease such as mitral stenosis, atrial stenosis, any valvular disease you want to say. Here, I'm checking for what? Lifts and heaves. They're rhythmic pulsations that lift my fingertips, common causes in large chambers of the heart, aneurysm. Okay? So we're done. Now we're to what? Auscultation, right? Again, when we auscultate, it's going to be on skin. So the gown opens anteriorly. It would open, he would shield. First thing I want you to do is palpate. Jugular notch, sternal angle of Lewis, second intercostal space, just lateral to the right edge of the sternum is what? Aortic valve is best heard here, right? Left, second intercostal space, just lateral to the sternum. What do I hear best here? Pulmonic. Erb's point, third intercostal space on the left side, just lateral to the sternum. Fourth and fifth, tricuspids, just lateral to the sternum on the left side. And then I would come out, he'd shield up. I'd palpate out to the fifth intercostal space on the left side, midclavicular line. Mitral valve is best heard there, right? At that point, then you're going to listen to each spot with the diaphragm and the bell. As you listen, you're palpating the carotid, right? So you would listen through with both. Does that make sense? Now, you're going to tell me a few things. When we listen with the diaphragm, we're listening to high-pitched sounds such as S1, S2, right? When we listen with the bell, low-pitched sounds such as S3, S4. I palpate the carotid while I listen because it helps me differentiate between S1 and S2. The upstroke of the carotid falls just after S1, before S2, right? As I listen, normal heart sounds, S1 and S2, I may hear abnormal heart sounds, right? I can hear murmurs from valvular disease, such as mitral stenosis or regurgitation. I could hear splits from slow closing of the valves, maybe pulmonary valve fibrosis, right? Does that make sense? So you give me two of them, just like that. I could hear gallops from non-compliant ventricles. I could hear a pericardial rub from pericarditis. Whichever two you want to give, and you're done. Does that make sense? So that's how you're going to do it. So practice these, practice them timed. I mean, you know exactly what the criteria is. It's either you do it or you don't, right? Does that make sense? Okay, so that's how we'll do it. Any questions? How long will you have? 10 minutes. Practice at time. Okay, start practicing. Don't wait till the last minute, because then it gets a little more difficult. Okay? All right.